Hello?
Hello?
Hi, Anita. Are you going to get started?
Oh, I was just waiting for Julia to say that we're all ready, so.
Yes, she's typed that in on the screen.
Okay, great. Hi, everyone. My name is Anita Molzan, and I'm a member of the CASN Research and Scholarship Committee. On behalf of the committee, I'm happy to welcome all of you to the November session of the 2018-2019 Lunch and Learn series. I'm sure that many of us are familiar with the concept of the Lunch and Learn, where faculty members come together during their lunch hour to share one or another project they're working on, and to dialogue and discuss methodologies, successes, and challenges they encounter in their work. The webinar series is intended to serve as inspiration and a networking opportunity for participants while recreating some of the collegial feel of Lunch and Learn. In this third session of the 2018-19 series, we're hearing from Dr. Shannon Scott, a professor in the Faculty of Nursing at the University of Alberta and a member of the Royal Society of Canada's College of New Scholars, Artists, and Scientists. She is an international leader in knowledge translation research and child health. She holds a Canada Research Chair in Knowledge Translation for Child Health and is a co-director of TREC, Translating Emergency Knowledge for Kids, a pan-Canadian initiative aimed at improving children's emergency care, where she co-leads the development of innovative family-centered tools to help families make decisions about seeking health care for their children. During today's webinar, titled Developing Knowledge Interventions for Parents, Dr. Scott will explain her research team's processes for developing knowledge translation tools. She will share the benefits and challenges of engaging healthcare consumers in our developmental processes and reflect on her team's experiences and lessons learned. After Shannon's presentation, we'll have time for questions. To submit a question for her, please use the question and answer function on your screen. You can do this during the presentation or after. Once you've finished typing your question, please don't forget to hit send. I will then relay the question to Shannon at the appropriate time. I'll now turn the session over to Dr. Shannon Scott so we can begin. Shannon?
Thank you very much, Anita. I hope that everybody can hear me well. It's my pleasure to join you for this Lunch and Learn session. Dr. Molzan has done an excellent job of outlining what I will be speaking about during our time together, so I don't need to go through that. Just to provide a little bit of context in terms of how we got started in terms of developing knowledge interventions for families, I always want to say that when we got started on this road in 2004, we were not sure where all of this was going to end up in terms of developing our program of work. I have a key collaborator, Dr. Lisa Hartling, who is an epidemiologist. She works in the Department of Pediatrics here, also at the University of Alberta, and we've worked together now for the past 14 years. And we started to use this notion of narrative and stories back in one project, and we had very favorable results. And so we took this whole notion of developing interventions with families, for families, together then in another grant several years later, a CIHR Knowledge to Action grant, and then worked together with our colleague Dr. Terry Clausen from the University of Manitoba to develop a large national initiative to improve children's emergency care across the country, where we partnered with general emergency room departments and partnered and linked them with pediatric emergency room departments to share knowledge. And an integral component of that was the development of interventions for families. And then in 2016, Dr. Hartling and myself were successfully awarded a CIHR Foundation grant, which allows us now to have 7 years of secure funding to be able to further develop these interventions. So I just wanted to show and share that with you so that you can appreciate that this just didn't happen overnight. It was very much sequentially developed, one study built off of another. So here are some images of some of our early development of tools. When we talk about interventions, people always want to know, well, what do they look like? I'm talking about the development of art and narrative-based interventions. So in this case, we started off with developing hard copy stories that had evidence-based information for the treatment of children's croup, overlaid with narrative, so families' experience. We then moved into developing whiteboard animation videos, as well as interactive infographics, e-books, e-audiobooks as well. And you can see from this image, we've also done work in translating our interventions into other languages and making them available in other cultural contexts. So the goals of our research were really to involve parents and families in the process of developing and evaluating these interventions, which makes this very unique. So it's not us as a research team developing these in isolation and then, implementing them in clinical practice. Families are very much part of the development and the evaluation process. The overall goal is to increase parents' confidence in managing common childhood conditions, increase their knowledge, as well as do true engagement with parents in terms of decision-making about use of healthcare services and treatments. So as I mentioned, we started off down this path in 2004, and that initial work was very much what I would call armchair theorizing. In other words, we thought that this approach of involving families and getting them involved in the development and hearing their stories would be useful. But as a nurse researcher, that always niggled away at me. I really wanted to get a sense of what did families want to know, what are their information needs and information preferences, and that was very much fundamental to developing these interventions. So back in 2011 and 12, I started down the process through our Networks of Centers of Excellence Knowledge Mobilization grant, where I developed and led a large pan-Canadian needs assessment of both parents' information needs regarding children's emergency care and healthcare professionals. And what we did was we did data collection in 39 emergency room departments, general emergency room departments across the country, from coast to coast, and as far north as Yellowknife, to really get a sense of what parents wanted to know. And this became foundational for us in the development of our interventions, because then we got a sense of the content area to focus on, as well as the format in which to offer our interventions. So the infrastructure that we have developed through our Networks of Centers of Excellence, where I'm a co-director, it's called TREC, Translating Emergency Knowledge for Kids. And what our premise is that we want to improve children's emergency care, irrespective of where they're whether they get emergency care in a pediatric emergency department in Canada or a general emergency room department in Canada. And as you can see on this slide, sort of the overwhelming push for this work is that 85% of Canadian children who need emergency care are treated in a general emergency department that's not part of a children's hospital. So we really wanted to be sure that these emergency departments that are treating the majority of Canadian children initially have the knowledge and skills that they need. And a really important arm of our work is focusing in on the parents, and that is the arm that I co-lead. So as all of us would appreciate as nurses, there are millions of visits in Canada to emergency room departments every year. There are many visits for minor conditions that could be treated in other settings or at home. And very recent research from CAIHI, which has suggested that 1 in 5 non-admitted ED visits for kids actually could be avoided. So we overlaid all of that with the fact that, because of these points, we really need to focus on finding innovative ways to empower families with the best available research evidence so that they can make the best available decisions given the situations that they are facing. This slide gives you an image where you can see where all of our sites are across the country. You can see with the green dot, those are our PERC sites, so those are our pediatric emergency departments. And then we have networked and linked with 39 general EDs, and those are indicated by the flags. Some of them are orange, yellow, blue, etc., just to give you a sense of where we started with. And we are growing our network as we develop more and more expertise, but this is where we started. So this is sort of one of our underlying principles of the work that we do, and this has been fundamental for us to keep in mind as we develop our knowledge interventions for families. Again, you can see with this Gordian knot, fundamental for our work was the large national needs assessment that I designed and led, and that provided very important data for us as we move forward and develop tools for healthcare clinicians as well as for families. These are just some of the results from our national needs assessment. One of the key factors that we go back to time and time again is this one question that we asked families: did they look for information related to their child's emergency situation before they came to the emergency room department? 39% of families indicated yes. So what we did was we actually did data collection in our sites across the country using iPads. We talked to family members while they were waiting in the emergency room department waiting room for care. So that was the frame of reference for these questions. So 39% of the families did ask for or did look for information before coming. Then we asked these families, well, where did they normally find information? Not surprisingly, 69% indicated from a trusted healthcare professional. More than half indicated they went onto the internet, and family and friends. So you can see that the top recorded or most frequently recorded places that they look for health information. And these data were fundamental for us as we started to develop this knowledge mobilization network. The results of our needs assessment were published a couple of years ago in the Canadian Journal of Emergency Medicine, where we looked at pediatric information-seeking behaviors. So in the first few years of our knowledge mobilization initiative, we were really trying to engage our end users to get a sense of their information needs and preferences to develop these interventions. Then we went forward for renewal of our network after the needs assessment. And in the renewal, we really focused then on the development of family tools. And that's also around the same time that we started to get a lot of traction as well through our CIHR Foundation grant. Again, the rationale behind sort of our innovative approach for developing our knowledge interventions is that we really strongly believe in the importance of empowering families with health information. But we do know that some of the most common ways of sharing information with the lay public can be confusing and overwhelming by virtue of the way we communicate information, the way we use jargon, and oftentimes what happens is that walls are built up between healthcare professionals and consumers rather than breaking down walls and truly having authentic engagement. So our rationale for using arts-based knowledge translation tools is that we believe that we're able to communicate complex health information and create this understanding while simultaneously generating meaningful connections and emotional impact. And our work has generated novel findings in terms of our ability of our tools to facilitate efficient memory and retrieval by virtue of embedding the health information within a narrative. Families have reported to us in our research studies how they do feel emotionally reassured and they're able to remember important details more effectively because of the story. And here are some of the feedback we've received from families. So as I've mentioned, our knowledge information, our knowledge interventions, or our knowledge tools for parents. We create animated videos and ebooks. They really are, I think, a strong synergy of the power of narrative and art. All of our tools now are accessible on mobile devices. We have started to do some really innovative work in tailoring our tools that have been developed largely for a Canadian context to multiple cultural groups and languages. And currently, they're organized by symptom and diagnosis. As we know, stories, the narrative, it's a very common way of communicating and sharing information, and there are so many benefits to embedding important information in a story in terms of making it memorable and in a way that's understandable. This is just an image of one of our early tools because people always wanted to get a sense of what our tools look like. And at first when we started down this path, we were unsure how to proceed. So we really involved families a lot from the start in terms of their preferences for look and feel. So we started off having our knowledge interventions really look a lot like children's books, actually. And that happened through a lot of focus group work with families through developing various prototypes and then getting feedback in terms of preferences. This just gives you a sense of the look and potential feel for them. You can see how we have different stories based upon the severity of the disease condition. We've also done randomized control trials of some of our tools. We currently have a pilot randomized trial happening now for our gastroenteritis whiteboard video to determine its effectiveness. We have a published RCT looking at the results of our croup books. It was a 3-site trial, and our main outcome was parental anxiety. Here's an example of some of our earlier work in terms of we understood the shortcomings of having hard copy tools back in 2004, and this was our earliest sort of attempt at taking this into the electronic age. So this was our first ebook on croup, where we actually embed audio within the intervention, so you can hear a child, how they sound with croup. We've had so many parents report to us how critical that was in actually determining, yes, my child does have croup, I know what I'm dealing with, and hearing that cough has been very, very effective. And then through the tools, we're able to inform parents exactly the steps they need to take and when they need to seek health care. This is just an image from one of our croup whiteboard animation videos. This video actually a few years ago won second place in a national competition for health videos. And this is our gastroenteritis whiteboard video. Again, we try to have our videos being approximately 3 minutes in length, really focusing in on the artwork and the narrative. In the 2016 national competition, it won an honorable mention, and this is the video we're currently doing the randomized trial in. Right now, we actually, our acute otitis media whiteboard video is in a national competition. I will send to Julie at CASN some information that we can send out to you. If you're interested in seeing this 3-minute long video, we would love for you to view it and to give us the thumbs up for our video, because for the month of November, this intervention actually is in a national contest. So I would encourage you to vote for us. Here is the link, so please feel free to click on the link after the presentation, watch the video, and one of the metrics for the competition is the number of thumbs up the videos get. So this is run through CIHR, this competition. So we know that through our national needs assessment that parents learn key information in different ways, and people have different information preferences. Families have given us sort of loud and clear the message that they want resources that they're able to get the key information quickly. We're able to do a lot of evaluative work looking at when parents stop looking at the videos, etc. And we're really aiming for that 3-minute length of video, because we're trying very hard to maintain their attention to that. One of the new areas that we've moved into is this whole notion of developing infographics and making them interactive. In other words, so that the end user, the parent on the other end of their mobile phone, that they're able to tailor the information to their respective situation. For instance, the age of their child, and they're able to get advice that is appropriate to the age of their child. So we have these infographics. We've got one developed on procedural pain and how to help their child when they get a needle poke, and things that parents can do to help manage that situation. We also have infographics on chronic pain, acute otitis media, fever. And as I mentioned, we're taking some of our tools that we've already developed and translating them into other languages, such as our croup whiteboard animation video. We're translating that into French. Last summer, I had a postdoc fellow working with me in my research program, and we took some of our infographics that we've developed for acute otitis media and had them translated and recontextualized for a new context in Pakistan. And my postdoc went to Pakistan and did focus groups with family members, focus groups with healthcare providers, did usability testing of our translated tools, and got really important feedback. And this manuscript is currently just under review. So we're hoping to leverage the whole development of tools that we develop for a Canadian context and be able to spread them to other parts of the world so that they can have effect, as well as learning important lessons too, given how multicultural our country is. This slide just gives a nice visual representation of the iterative nature of our tool development process. You can see at the top in the sort of bright pink or fuchsia, this is where we started with our national needs assessment. Then in the blue, if we're going clockwise, we do parent interviews simultaneously with knowledge synthesis of the key information. So in terms of reviewing all of the literature out there on parents' information needs and preferences for each respective health condition we're developing tools for. And that's, of course, overlaid with the best available evidence-based recommendations. We develop prototypes of tools, and they come in many different forms. Then we get initial feedback of our prototypes. We have national experts through our TREC and PERC platforms that provide vetting of all recommendations provided in all of our tools. And we also have prototypes that we get feedback through our parent advisory group. So I have a parent advisory group that I've developed that informs my research program. It's 28 families that volunteer their time monthly and provide feedback on any prototypes and research products that are being developed in my program. Based upon this feedback, we do tool refinement or intervention refinement. And then we go across the country and do usability evaluation of our tools to understand parents' reactions to the tools in terms of how usable they are, how clear they are to understand. And we conduct this usability evaluation in emergency department waiting rooms while families are waiting for care. And we've purposefully done that because we do believe that families are going to be accessing our tools when they are managing an ill child at home. So that's why we want to have a comparative type of user in our usability testing. We also do translation and cultural adaptation work, and then we do broad-scale dissemination and implementation. We're very fortunate through our TREC Knowledge Mobilization Initiative. We have a well-established platform on www.trec.ca that house all of our tools. We also have embedded social media plans for all of the dissemination as well to get our tools out there and used. And of course, there's a whole other element that isn't discussed on this image where we are constantly refreshing our tools. In other words, we're keeping abreast of any latest developments or changes in evidence-based recommendations that would require us to make amendments to our tools. Here are some of the sites that we've done usability testing of our tools in. So for every new knowledge intervention that we develop, we want to do usability testing in an urban, a rural, and a remote site, and we purposely varied these sites across Canada. This image just gives you a sense of our productivity in terms of the content areas where we have developed knowledge interventions for families, with families in the recent years. So we've developed 3 ebooks and whiteboard animation videos for croup. Asthma, we have an ebook. We've developed an ebook and whiteboard animation video for gastroenteritis. For procedural pain, we have an interactive infographic and whiteboard animation video. Acute otitis media, the same. For chronic pain, this was a very unique partnership that I had with our Stollery Children's Hospital Pediatric Chronic Pain Clinic, where they made a specific request to me. And so I wrote a specific grant to develop tools for their population. And these tools actually, they are posted on the Alberta Health Services website, but they've also been picked up by other healthcare organizations globally that have really found benefit for our ebook and audiobook. We have developed a whiteboard video and interactive infographic for fever, and we are in the process now of developing tools for bronchiolitis and UTI. So these are just sort of the ones we've got under development. And then I have many doctoral students and master's students working in my research program, and they are also using the same model, but developing tools for other conditions that were identified in our national needs assessment. This provides a very rich training ground as well for trainees in terms of making important contributions to knowledge, to nursing knowledge, while also having the opportunity to develop an intervention in doctoral work, for instance, and then having the ability to do effectiveness work, for instance, in a postdoc. This image just gives you a sense of our PPAG, we call it, our Parent Advisory Group, and this has been fundamental for us in the development of our interventions because I view them as being co-developed. This is just not my research team developing these. We're actively working together with families in our Parent Advisory Group, and this image just gives you a sense of sort of the progression of the Parent Advisory Group and the types of tools that they have made very meaningful contributions to. And very true to this whole notion of co-development is that I work hard to ensure that family members do feel as though they are very meaningfully involved. So just this past June, one of the members of our Parent Advisory Group, he came to a national meeting with me, and we co-presented some of our research findings. It was a bit of an interesting situation to be able to, convince sort of a scientific, committee that, somebody that was not a healthcare professional and not a health researcher could be co-presenting research with us. So we really feel as though we're kind of blazing a new trail in terms of this, but it is very important to us that we are co-presenting this work. And just 2 weeks ago at the Canadian Association of Pediatric Health Centers national meeting, another one of our Parent Advisory Group members also presented with me on the importance of developing advisory groups to inform health research. So just to wrap out, in terms of sort of our lessons learned, I feel really strongly that work like this is important, the co-development, so working together with end users to ensure that health evidence does get in the hands of those that need this information. We need to work together in improving parent confidence and knowledge through innovative strategies such as these interventions, I believe also has the potential for more efficient use of healthcare services as well as improved quality and continuity of care. So I just want to stress our work is not about preventing families from seeking healthcare. It's not about preventing families from going to the emergency room department. It's about empowering families with information so they can make the best decision for the circumstance that they're currently dealing with. It's really about empowering families and democratizing knowledge so that they can make informed decisions. It's about engaging families and building this community and really involving families in the process. So I've shared our process of developing knowledge interventions for parents. Our process values this co-development. We have done some effectiveness evaluations of our interventions, either through pragmatic randomized control trials or through RCTs. And now as we have developed, we've got a nice base of interventions. We are going to be proceeding to do more and more RCT work in the future. Our work has highlighted how supportive parents are of this sort of innovative synergy of arts and narrative-based mediums for communicating health information. Our usability evaluations across multiple studies have identified that these types of interventions are highly usable, they're well accepted, and they have excellent uptake. Our evaluations have also demonstrated that KT tools can, like these, can inform decision-making and shape treatment outcomes. And our model for patient engagement and development of innovative and relevant KT tools has been highly successful and is scalable to other conditions and other populations. And we're starting to, while we are developing more and more tools for emergency care, we have recently received funding from our Stollery Children's Hospital Foundation to allow us to focus in other areas sort of beyond emergency care. I just also want to stress that co-developing knowledge interventions with parents results in interventions that will be used. However, working with end users does result in us as researchers having less control over timelines and processes. And personally, I'm okay with that. But I always like to share that with people, is that when you are doing meaningful engagement with end users and they are influencing the process, you're giving up some control over a whole bunch of the decisions. The development of our advisory group has been absolutely critical to our success. But developing an advisory group like this takes time, energy, and resources. I'll be the first to admit that we dreamed of having an advisory group for many years before we actually started and formally got one in 2016. We were really unsure of how to do it. So we just started by, kind of dipping your big toe into a swimming pool. We were unsure. We were kind of testing it out. We were unsure where to recruit parents. We started with social media, posters across campus and healthcare settings. We met, we sort of interviewed informally those that expressed interest to see if there was a fit. And at first, members of my research team chaired these meetings, but we wanted it to be really co-led. Now we have a parent actually leading the meetings. But that took time and energy. And between the meetings, there's a lot of time, energy, and resources that go into keeping this sustainable and to maintaining interest and engagement. What was interesting is that as a team, we were so sensitive at the start that we didn't want to burden our advisory group. And then we conducted a formal evaluation, and then we learned that actually our parents wanted to meet more frequently. At first, we were meeting every other month. We did an evaluation with our parent advisory group, and they told us, we want to meet more. We actually want to get more involved, and we were astounded. Just this week, actually, I hired a part-time engagement coordinator in my research program who is going to further grow our parent advisory group and enhance engagement. Right now we have 28 members, and we want to grow that group, and we also are going to explore having a youth advisory group as well. So that's sort of my presentation in a nutshell. I just wanted to thank you very, very much for your attention, and I welcome any questions that you might have. I also, here is my email address if you want to email me after, and I just want to extend my appreciation to the funding agencies that have supported my research over the years.
Thank you so much, Shannon. That was an amazing presentation about a huge amount of work. We've had a couple of questions submitted, and I'd encourage others to submit questions if you still have some. But the first one was from Cindy, and her question was, I understand that anxiety and depression are increasing amongst young persons, to say nothing of suicide and substance abuse. Are there any plans for mental health areas?
Absolutely. Thank you, Cindy, very much for your comment. Absolutely, that's certainly on our horizon. And through our new pot of money from the Children's Hospital Foundation, that's one of the areas that they've actually asked us to move into. Certainly, in order to be able to do that work and to do that work of a very high quality, we are going to need to partner with mental health care professionals to come on board in the development of those tools, but certainly we do want to move into that area. So thank you.
And then Suzanne had a couple of questions. One was about the link to the handouts and to the vote. Now, I think those were in the presentation. Do you want to maybe just read them out again, yes. Shannon?
Yes, for sure. So thank you, Suzanne. So from what I understand, and Julia, please chime in here if I'm not correct, my presentation will be made available on the CASN website, so you will be able to see the slides. And in there, the link is provided, and that may be easier than me reading out the whole link for you to go in and access it. But just to provide a bit more context, where that link will take you is for the month of November, the Canadian Institute of Health Research on their YouTube channel has a special contest through the Institute of Human Development, Child and Youth Health, and it's called the Talks Competition. And this year there are 27 videos entered. So for the month of November, all of these 27 videos are just put on the YouTube channel, and part of the evaluative criteria of who wins the national competition and the bragging rights of being the top ranked video is the video that gets the most thumbs up. And we have been working so hard and pushing this out on social media, and we have lots and lots of views. So people are viewing it, but they're just not hitting the little thumbs up button, and that is what this competition is counting. So I would love it if all of you could share this link within your networks and to spread our video on how families can manage ear pain and when do they need to seek care, and giving us the thumbs up. I'd really appreciate it.
Thanks, Shannon.
Hi, Shannon. This is Julia from CASN. I just wanted to just jump in and say I can, right after this session, send out that link to all the participants that, that registered for our webinar today.
Okay, thank you so much.
And then Suzanne had another question. Wondering about infant feeding and the failure to thrive in dehydration in infants.
Great. Thank you, Suzanne, for that point. As I mentioned, sort of what's guiding the initial sort of first 20 tools that we develop are the results from our national needs assessment. So what parents said that they wanted information on. Unfortunately, what you've brought up about infant feeding and failure to thrive wasn't in those top 20 conditions. It doesn't mean we're not going to move in that direction, and certainly if there's interest and demand in other ways and if we have resources available, we are more than willing to develop interventions in those areas. Again, it's just sort of managing priorities and resources and honoring the results of our needs assessment.
Great. Thanks, Shannon.
Great. Thanks, Shannon.
Are there any other questions? I might ask one quick one, just in case others are just formulating their thoughts. But I was curious, Shannon, about the translation and cultural adaptation. What's your experience with that? Did you have to make many changes? Was the response positive in other cultural groups?
Great question. So I just wanted to start off by saying it's not as easy as people think. It's not taking a video in English and hiring a translator to put the video into French and then doing back translation and checking. What this work actually involved was some of that, so doing some translation work, but also doing focus groups to ensure that images are appropriately received, etc. And certainly our work in Pakistan required much more adaptation by virtue of the fact that different policies and procedures and recommendations are in place in terms of, in this case, managing children's ear infections. Because in Pakistan, you don't need a prescription from a physician, for instance, or another healthcare provider in order to get antibiotics. So, of course, we needed to do that kind of adaptation. So it really depends upon the cultural context of where we want to go. We're also working with Indigenous groups right now to take some of our tools and have them adapted for their cultural context. And it's, in some cases, it is almost like starting off at square one because we need to do parent interviews again to incorporate their experience into it. So, I'm sorry if my response is not satisfying in terms of it really depends. I just would offer some caution that it isn't as straightforward as we thought it was going to be.
Well, that's good advice. Well, not seeing any other questions. I just want to say thank you again, Shannon. An amazing amount of work, and I know that there are a number of people that I will pass your links on to. Good luck on the vote. And to everybody else, thank you for your participation today. After today's webinar, you'll receive a short evaluation survey regarding today's session. It shouldn't take more than 5 minutes to complete, and we really appreciate your opinion. We'll use it for planning future sessions. As you've heard earlier, the recording of this session will be made available on CASN's YouTube channel and circulated to you in the coming days. Feel free to share
share the link within your network.
And thanks again, everyone.
And thanks again, everyone. And thanks again, Shannon. CASN certainly hopes that you'll consider attending other Lunch and Learn sessions. And just visit CASN.ca Lunch and Learn for more information.
Thanks again for joining us.
Thanks again for joining us.